Welcome to an NRG Oncology podcast coming to you from the 2026 Multidisciplinary Head and Neck Cancer Symposium in Palm Desert, California. While much of the country is still digging out of the winter snow, every February the Multidisciplinary Head and Neck Symposium is in a warm, sunny venue, making it a very popular conference and making me here in Cleveland very jealous. All joking aside, some of the most important advances in the management of head and neck cancer are presented and discussed among multidisciplinary specialists from surgical, medical, and radiation oncology. Today, our first guest on the podcast is Dr. Paul Harari, presenting the first results on NRG-HN009. Dr. Harari has had a storied career in head and neck oncology, having led numerous translational studies and clinical trials for decades. In the field of radiation oncology, Dr. Harari was chair of the Department of Radiation Oncology at the University of Wisconsin-Madison from 2007 to 2024, served as the 2017 president of the American Society for Radiation Oncology, or ASTRO, and received its highest honor, the ASTRO Gold Medal, in 2024.
Today, Dr. Harari presents the first results of NRG HN009, which is a clinical trial looking at different doses of concurrent cisplatin-based chemotherapy for cancers of the throat, or as we call them, oropharynx. Every medical student learns about cisplatin in pharmacology as an alkylating agent that affects cancer cells by interfering with DNA replication. But to prepare for this podcast, I did a quick Google search on cisplatin just to refresh myself. I had not realized that it was first described in 1845, but it wasn't until 1965 that it was discovered by accident that it could kill cancer. Then it was approved by the FDA as one of the first chemotherapies in the 1970s. Dr. Harari, welcome to the podcast. Let me ask, for something that was discovered almost 200 years ago, has been used in humans for almost 50 years. Why are we still trying to figure out what the optimal dosage is for throat cancers?
Well, that's a great question. Thank you, Dr. Chun and Dr. Henke, for the invitation. It is remarkable that we deliver cisplatin along with radiation for so many of our common solid tumors, such as head and neck cancer, but it remains unclear which specific dosing and administration schedule is best for head and neck cancer patients. Many centers around the world use Q3 weekly cisplatin, typically 100 milligram per meter squared, but many centers use weekly cisplatin at 30 to 40 milligram per meter squared, and this is exactly what has prompted the NRG-HN009 study, which is the best schedule for patients in terms of head and neck cancer control and toxicity.
The design of HN009 seems pretty straightforward as clinical trials can go, but I wanted to quickly cover the basics for those out there unfamiliar with the study. Essentially, patients with cancer of the oropharynx or throat plan to receive cisplatin-based chemoradiation were eligible. Half of patients received low-dose weekly cisplatin, and half received high-dose cisplatin every 3 weeks. Can you go over with our audience exactly how radiation was done in the protocol? And could you also briefly talk about the difference between P16 positive and P16 negative cancers and why those groups are looked at separately in HN009?
Of course. Let's touch on a few basics about the HN009 trial. These are patients with locoregional squamous cell carcinoma of the head and neck treated with curative intent. Remember that patients would not be eligible if they presented with distant metastatic disease. So curative intent, therefore 70 gray radiation over 7 weeks is the backbone treatment. There's minor flexibility in radiation scheduling. Centers that prefer 2.12 gray fractions times 33 are okay, but majority of patients in the study have received 2 gray daily fractions to 70 gray. IMRT is the treatment technique for all patients. However, it's okay to use either photon radiation or protons, depending on center preference. The study included both P16 positive and P16 negative patients, as these groups are analyzed separately because they have very significantly different survival outcomes, with the P16 patients faring much better in outcome stage per stage.
Here at the Multidisciplinary Head and Neck Symposium, we heard the first results of HN009. Can you fill in our audience what the initial results of HN009 show? And are there any practice-changing or practice-defining implications of these results?
I want to set the stage very carefully to be sure the audience is in tune. Yes, this is the first public report of NRG-HN009 data, and it's important to note that this initial report presents only the acute toxicity data from the phase 2 P16 positive cohort. Note that HN009 is a phase 2/3 study, where the phase 2 results guide whether the study proceeds to phase 3. Also, as we mentioned, the P16 positive and P16 negative cohorts are analyzed separately due to the differences in outcome for these two cohorts. Also, critical to know that the primary endpoint for the phase 2 study is the 6-month acute toxicity profile. This primary endpoint determines whether the P16 cohort progresses to the phase 3 segment of enrollment. Same for the P16 negative when we come to that. If the acute 6-month toxicity profile is lesser using the weekly platinum schedule versus the Q3 weekly, then the cohort proceeds to the phase 3 enrollment. Again, that same process will follow for the P16 negative cohort in the next 6 to 8 months, since accrual was a few months slower in the P16 negative group, and we need some more time for that to mature. This initial report demonstrated that the 6-month acute toxicity profile for the P16 positive cohort, as analyzed by T-score, TAME score, were virtually identical for the two arms. The TAME score measures the number of treatment-related grade 3 to 4 adverse events during treatment or within 180 days after treatment. Therefore, the P16 cohort will not proceed to phase 3 enrollment.
So I think that gives a nice overview of when to kind of expect the next steps with this trial to emerge. And I am very excited to see how all of this plays out beyond just these initial toxicity results. You mentioned something as you were describing the radiation and the study design that I just want to point out as being very pragmatic, which is the flexibility used in the radiation scheduling, as well as flexibility around the modality, whether it was protons or photons, at least within, a range of things that are expected to have similar oncologic outcomes. What made you and the investigators helping to design this trial decide to leave that flexibility there? I think it certainly can help with things like accrual when a center is allowed to choose between photons and protons based on their practice patterns. But were there obstacles to having the trial set that way?
That's also a great question, and it brings up a really important point that I'm glad that you mentioned. This is a very pragmatic trial, as you recognize. This is essentially just asking, is the Q3 weekly or the Q weekly schedule preferable for our head and neck patients around the world that are undergoing this challenging treatment? And we didn't want to raise barriers for enrollment, as you noted, and that is a very significant element for a pragmatic trial. Some institutions are so wed to a certain fractionation or the use of proton or photon if they have both of those available. We really wanted this to represent institutional practice, not only in North America, because we had centers from several countries around the world who enrolled, and we wanted it to reflect that worldwide practice. And there were also quite a valuable contingent of community practice centers that enrolled and participated in the trial as well. I want to add one really key point. When I mentioned that the key first result of this initial report is that the 6-month acute toxicity profiles were essentially identical, it's also important for me to mention that the 6-month local regional failure rates on the two arms were also identical. In fact, statistically, they were identical. It was a little bit lower on the weekly cisplatin. Only 2.7% of the patients experienced a local regional failure in the first 6 months, but very similar number, 3.5% local regional failure on the Q3 weekly cisplatin arm. So that's really important for the audience to know that at this early time point where we're looking at acute toxicity, we have virtually identical cancer control rates.
I want to delve a little further into the specifics of the data that was presented on HN009 at this multidisciplinary symposium. In looking at some of the data, it seemed already emerging in this population that there might be some differences in the toxicity profile between the two arms, the high dose and the low dose cisplatin groups. Could you speak a little bit about the specifics that you observed looking through the data in terms of the toxicity profiles?
Again, even though this is early 6-month acute toxicity, we did see a different profile of the acute adverse event toxicities between the Q3 weekly and the weekly schedule. And that data essentially showed that there were certain types of toxicities that appeared much more common in one arm than the other. For example, the weekly cisplatin arm, where they're getting 40 milligram per meter squared of platinum each week with the 70 gray of radiation, it was more common for patients to report grade 3 or 4 pain, fatigue, anorexia, a decrease in their white blood count or platelet count. However, on the Q3 weekly cisplatin, it was much more common to see grade 3 to 4 acute kidney injury, dermatitis reactions, and hearing impairment as graded by the adverse event profile. So that profile was quite distinct. And although the overall sum of a TAME score is the total number of adverse events that accrue in the grade 3 to 4 segment, this really revealed that the profile of those adverse events differed quite a bit between the two arms.
And I did notice that, at least numerically, I know the numbers are small, but there seemed to be more patients who actually died from the high dose cisplatin given every 3 weeks than patients who were given a low dose once per week. Are the numbers just too small for us to make anything about it, or can we draw any conclusions in your estimation?
No, I'm glad you asked, Stephen. I guess I would say we cannot draw any early conclusion from that yet because the numbers are very small and, at least at this point, no significant difference, statistically speaking, in those figures.
I know that clinical trials are always a huge team effort. And so we always like to give our guests the opportunity to recognize key team members. Who were the major players in HN009 who really helped to make this clinical trial possible?
Yes, thank you. It is a pleasure and a joy to recognize some of the many individuals who participated and were so instrumental in the trial. These are big efforts, as you know, and so thank you for asking about that. There were several radiation oncology co-chairs along with my involvement. Those include Dr. Quinn Lee and Dr. Matt Wittick. Several medical oncology co-chairs, Dr. Christine Chung and Dr. Jed Katzel, a QOL co-chair, Dr. Farzan Siddiqui, medical physics, Shi Lu, translational research, Scott Bratman, pathology, Brittany Holmes, otology, Jeff Sharon, and the NRG Head and Neck Committee Chair, senior author Dr. Sue Yong. But I'd also like to just mention very briefly some of the lead accruers. 475 patients have been enrolled in the phase 2 segment, and this is an enormous effort throughout the country and throughout centers from overseas. The lead accruers were Dr. Michael Russin from the Kaiser Permanente system, Dr. Adam Burr from the University of Wisconsin, Dr. Chris Lominska from the University of Kansas, Dr. Coral Lazagasti from the University of Miami, Dr. Kathleen Kerrigan, University of Utah, Dr. Vachi Chekmedian, Maine Health Cancer Care, Dr. Martha Manda Mapalo, New Mexico, Minority Underserved, NCORP, and Dr. Phil Shaner from the Dartmouth Cancer Center. So, yes, I'm so pleased to be able to mention their names. And Stephen and Lauren, if it's all right, I have one other element that I would like to come back to, if that's all right.
Oh, by all means.
I know that I mentioned, coming back to the data from today's presentation, that the phase 2 P16 acute toxicity results will mature this summer and hopefully report in the fall, possibly Astro in Boston. We absolutely wait with high interest for these new data, because possibly the acute toxicity phase 2 results for the P16 negative phase 2 will parallel those of the P16 cohort reported today. However, we need to wait and see that data. It may not be the same. That analysis will determine whether the P16 cohort will proceed to phase 3 enrollment of HN009 or not. And finally, one other element I should mention. There are several potentially very important secondary endpoints of HN009 that will emerge over the next year and beyond. For example, to better assess hearing loss as measured by audiograms, as well as hearing-related quality of life as measured by the hearing handicap inventory screening that was taken by all patients. This will be very revealing data about whether there are differences in these domains across the two arms. We will also assess patient-reported QOL, quality of life outcomes, to compare the two arms of the study. And again, these may demonstrate similar outcomes between the study arms, or they may demonstrate significant differences that will be valuable for head and neck cancer patients and their cancer providers to be well aware of.
We really want to thank you, Dr. Harari, for coming on the NRG Oncology podcast. We look forward to having you back, perhaps when those final mature results of HN009 are back in continuity. And I appreciate your pointing out the need to be patient as we wait to see how the different P16 cohorts play out and how all of these results come together over time. And even when we get results back from your other NRG oncology trial, RTOG-1216.
Well, thank you very much. Thank you so much to both of you for having me today. And I'm certainly happy to return in the future to share additional new study results as they become available.
Next up on the podcast for this 2026 Multidisciplinary Head and Neck Symposium, we have Dr. Alan Ho talking about cancers of the saliva glands, specifically about the kinds of salivary cancers that express human epidermal growth factor 2, or HER2. For those of you who want to know more background on the history of HER2, you can listen in to our previous NRG Oncology podcast on the HERO trial with Dr. Lear Brownstein and Dr. Melissa Mitchell. Dr. Alan Ho is the Chief of Head and Neck Oncology at the Memorial Sloan Kettering Cancer Center. He's also the National Principal Investigator of NRG HN010 for HER2-positive salivary gland cancers. Dr. Ho, salivary gland cancers are probably one of the more rare tumors we deal with at NRG Oncology. Can you first just give us some general background on salivary gland cancers? What exactly are salivary glands? What are the risk factors for developing a salivary gland cancer? And what general things should everyone know about salivary tumors?
Thanks so much for having me on, and really appreciate this opportunity to talk about salivary cancers and the clinical trial we're leading through the NRG Oncology Group. First of all, when we talk about salivary gland cancers, these are tumors that arise from both major glands and minor glands. Major glands are defined as the salivary glands you can see, the parotid, the submandibular, and the sublingual glands. But then all throughout your upper aerodigestive tract are microscopic salivary glands that you can't see. Oftentimes, patients with tumors of the tongue, the pharynx, or the sinuses will come and we biopsy it, and it's not squamous cell carcinomas. It turns out it's some other strange histology. Those are typically tumors that arise out of microscopic minor salivary glands. As you mentioned, these are incredibly rare tumors. These represent only 5% of the tumors that arise in the head and neck. What makes it even more challenging is that these tumors are quite diverse. There are more than 20 different subtypes of salivary tumors. So while this is an incredible area of therapeutic need, conducting clinical trials can often be quite challenging given the rarity and the heterogeneity of these diseases. In terms of risk factors, not a lot is really well known. There are certain subtypes that are associated with age. Also, we know that therapeutic radiation exposure can increase the risk of some salivary cancers. Then there are other environmental exposures and dietary issues that have been connected, but a lot of that research needs to be more fully developed.
In your trial, HN010, the NRG Oncology Group is looking at the specific subset of salivary cancers that express HER2. What percent of salivary tumors express HER2? Do HER2 positive salivary cancers behave in any way like HER2 positive breast cancers, for instance? And are these HER2 positive salivary gland cancers more aggressive or less so than non-HER2 expressive salivary cancers?
In the last decade or so, we've learned a lot about HER2 and its relationship to salivary cancers. Among salivary duct carcinomas, overexpression or amplification of HER2 can occur in up to 30 to 40% of that disease. There are other histologies that also express HER2, but at lower percentages. Those include adenocarcinomas, nucleoepidermoid carcinomas, and actinic cell carcinomas. There are many similarities, actually, both pathologically and biologically, between breast cancers and salivary duct carcinomas. And indeed, we can see a lot of parallels between HER2 positive breast cancers and HER2 positive salivary cancers. With regards to whether or not this is prognostic in salivary cancers, the data is a bit mixed, with most of the data demonstrating that HER2 positivity is not associated with poor prognosis in salivary cancers. But I think, again, a lot more research is needed to better thresh that out.
I imagine that we've taken a lot from the HER2 positive breast cancer playbook here for these HER2 positive salivary gland cancers. As background for your trial, I wonder if you could speak about the current treatment paradigm for HER2 positive salivary gland cancers, let's say outside of a clinical trial like your own, and what are the outcomes like in this population?
There are many limitations for how we develop therapeutics for rare cancers, but one of the tried and true ways is taking the same molecular alteration from a more common disease and extrapolating the practice paradigms to the rare disease. And that's exactly what we've done with HER2 and salivary cancers, where indeed we are taking a lot from the breast cancer playbook and how HER2 therapeutics were developed there. When you trace out how HER2 therapeutics have been applied in salivary cancers, at first it was a series of case series and case reports about how the HER2-directed antibody trastuzumab alone or in combination with chemotherapy might have efficacy in these diseases. What then came were several different small cohorts on different clinical trials demonstrating the efficacy of HER2-directed approaches. More recently, two larger phase 2 trials, both done in Asia, demonstrating the efficacy of docetaxel plus the HER2-targeted antibody trastuzumab in HER2-positive salivary gland cancers. If you were just to look at that combination in those phase 2 studies, that combination of drugs, docetaxel and trastuzumab, produced extremely impressive response rates, about 70% in HER2-positive salivary gland cancers, with progression-free survivals in the 8.5 to 9-month range. However, the limitation is that these are only single-arm phase 2 trials, and the other HER2-directed approaches that have been tested have been done so in much smaller cohorts, still with very promising outcomes. So what we're really faced with in the field is being able to delineate which are the better treatment approaches, which are the treatment approaches that should be prioritized for these patients. And this is one of the central questions that our clinical trial is meant to address.
Well, that is kind of a perfect segue. So, with all of this in mind, can you explain in depth the rationale and design for HN010? What are the major goals that you're seeking to accomplish through this trial? And who exactly is eligible for this study?
As I mentioned, The HER2 targeted strategy that has been tested the most comprehensively so far, and that's limited to two single arm phase 2 trials, is the combination of docetaxel plus trastuzumab. But there have been many promising signals with other HER2 directed approaches, most prominently antibody drug conjugates such as adotrastuzumab emtansine or trastuzumab deruxtecan. These have also produced overall response rates that are similar to the trastuzumab docetaxel data. With that in mind, the question that we're really trying to address in this clinical trial is what is the optimal first-line therapy for patients with HER2-positive salivary gland cancers that have recurred or are incurable? The patients that we're really looking for are the patients with recurrent metastatic, unresectable HER2 overexpressed and amplified salivary gland cancers. Those patients, if they have not received prior treatment for their recurrent metastatic and unresectable disease, can then be enrolled and then randomized either to the control arm, which is trastuzumab plus docetaxel, versus the experimental arm, which is adotrastuzumab emtansine, or which we abbreviate as TDM1.
Let me just ask real quickly, why is one arm the control arm and the other one considered experimental?
So I think, in fact, by the traditional measures of what would be considered standard of care, neither of these could potentially be labeled standard of care, except that with docetaxel trastuzumab, it's been evaluated in the highest number of patients in a prospective clinical trial. Among the two phase 2 studies that have been done in Japan, docetaxel plus trastuzumab has been evaluated in about 100 patients with HER2 positive salivary gland cancers.
So if I understand correctly, essentially we're comparing a regimen for which there is more experience with a regimen which there is somewhat less experience with, but we believe that the less experienced regimen, there's reason it would work better.
That's right. In this particular case, we're comparing the regimen of docetaxel trastuzumab, which has been evaluated in about 100 of these rare cancer patients, with TDM1. Now, TDM1 we've evaluated in a basket study of less than 20 patients. In that particular study, the response rate again is over 70%. The progression-free survival is about a median of 15 months, but in a much smaller cohort of patients. So what we're trying to say is, if you were to look at the landscape of therapeutics for these patients and what regimen is supported by the most prospective data, that would be docetaxel trastuzumab. That would be our quote-unquote control arm. While TDM1 would be the more experimental approach, given that it's evaluated in less patients. Now, what is the potential advantage of the experimental arm? Well, what's really nice about this comparison is that docetaxel trastuzumab is a combination of an antimitotic plus a HER2-directed antibody. Mechanistically, these two approaches are similar. They're just delivered in different ways, where the antimitotic is delivered independent of the HER2-directed therapeutic with the trastuzumab docetaxel combination, and in TDM1, they're covalently linked within one drug. The potential advantage of this is that TDM1 may be more tolerable and be able to be maintained for longer. And so the primary hypothesis we have here is that while the response rates for docetaxel trastuzumab and TDM1 are going to be similar, the progression-free survival with TDM1 may in fact be longer. But that, of course, remains to be proven within this clinical trial. Now, in the clinical trial, there's also crossover allowed. So when you progress on either the docetaxel trastuzumab or the TDM1, at the time of progression, patients are also allowed to cross over to the alternate therapy, which will give us some information about the ability of these regimens to overcome resistance of the other. And again, help us to gain clarity about the optimal order in which these drugs should be administered.
I wonder if biomarker testing for things like HER2 have been widely adopted for salivary gland cancers. I know that breast cancer has really led the way in terms of personalized biomarker testing for things like HER2, the estrogen receptor, and now a number of other targets. I want to ask, should centers be routinely testing salivary gland cancers for HER2 expression? I know that in a number of other cancers, testing for receptors and biomarkers is highly variable. Has a lack of testing in any way contributed to accrual challenges with HN010 since we're looking at such a specific population? And how do you suggest we overcome barriers to HER2 testing for salivary gland cancers? For example, with breast cancer, it's a reflex test where the pathologists get a sample and they reflexly, without being told, just do the testing. Are we seeing that with salivary glands? And is that a potential problem here?
Yeah, you've hit upon one of the challenges to completing a trial like this. In academic centers where there's greater awareness of the data of HER2-directed therapies and the expression patterns of HER2 in salivary cancers, HER2 status is more reflexive among academic pathologists, but of course in the community, less so. You'll find that in non-academic centers, oftentimes the HER2 positivity of a tumor is only revealed incidentally if next-generation sequencing is sent and an amplification is found. I think there's different orders of what you would like to see. I think broadly, it makes sense to reflexively just test HER2 immunohistochemistry in all salivary gland cases. If you really want to get sophisticated about it, you could limit that testing to the histologies where HER2 expression is known to be of the highest percentage, such as salivary duct carcinomas, adenocarcinomas, mucoepidermal carcinomas, etc. But I think that kind of level of expertise is really not necessary. At this point, doing reflexive HER2 IHC and followed by in situ hybridization would be a very acceptable paradigm for salivary cancer pathologies.
Let me just ask one quick follow-up question. Our current paradigm for these HER2 positive salivary gland cancers is to target the HER2 protein through the approaches you've talked about. But let's say a patient undergoes a biopsy, shows salivary gland cancer, pathologist doesn't test for HER2, and let's say the patient does have HER2 amplification. And let's just say they're tested without HER2-directed therapy. How much worse would you expect their outcome to be if they were treated without knowledge of their HER2 expression versus being treated specifically with HER2-directed therapy?
Well, we don't really know the answer to that question, but I will kind of answer it in the positive, which is that when you look at across all the targeted therapy and chemotherapy data that we have, the best response rates and median progression-free survival numbers that are generated from those studies for HER2 amplified tumors, the HER2-directed therapies are always the best. So this is why when I see HER2 overexpression or amplification, I always prioritize HER2-directed therapies for those patients, knowing that the greatest degree of efficacy is going to be found in those therapies and those combinations. The other aspect of this that's kind of interesting is that in salivary duct carcinomas, where HER2 overexpression is the most common, those tumors also tend to express the androgen receptor. And there is a body of literature demonstrating that androgen-directed therapies can also have efficacy. But we and others have also already found or observed that in the context of HER2 overexpression and amplification, AR-directed therapies have less efficacy. So that is one example where another targeted approach in the same histology that expresses both biomarkers, HER2 is meeting resistance to the targeted agent. Again, lending support to the idea that HER2-directed approaches should be prioritized for these patients.
I wonder if you could tell us a bit about how you frame this study to your patients, both in terms of potential benefit and potential risk. I think it's really interesting study design for a rare cancer like this, with both of these arms being, as we've talked about, not necessarily the result of years of randomized phase 3 trial data. I imagine that creates an additional layer of challenge. Could you lay out how to best represent the study in layman's terms to patients who might be considering enrolling on this protocol?
What I like to do with patients is give them the context of where we are in the field right now. It's a rare disease where there has been an explosion of interest and discovery over the last decade. The real promise of where we are right now is that 10 years ago, none of these options would have been considered. But what's happened in the last 10 years is we've learned so much about the HER2 target in salivary cancers. We have a variety of different signals from retrospective cohorts and small prospective cohorts that demonstrate that these approaches have efficacy. We've now graduated to the second stage, which is now to question. We have all these different treatment options that all demonstrate efficacy, but we really now need to do the hard trials of demonstrating which of these should be prioritized in the first-line setting for these patients, and really optimizing the order in which these drugs are administered. The two options that patients get randomized to in this particular trial, the docetaxel trastuzumab versus the TDM1, we know both of these regimens have a high degree of efficacy, so I am not worried about them receiving a drug regimen that doesn't work. Instead, what I'm trying to delineate is which of these should be optimally used first. And that is a question we really have no answer to. And they also have the opportunity to receiving the drug they're not randomized to in the second-line setting as well.
Despite the rationale you've laid out on this podcast and also with the NRG oncology community, we've seen challenges with meeting accrual targets. What sort of hurdles are you seeing out there for HN010 other than the biomarker testing we already talked about? And how can we as an NRG oncology community help overcome these hurdles?
There's no doubt that this particular trial is ambitious. This represents the only randomized trial done within this specific rare subset of diseases. It's trying to establish a new standard of care within the field, not to mention the fact that there is no standard of care. There's never been an attempt to establish a standard of care for these patients. That alone is quite challenging. I think the issue here is when providers see a HER2-positive salivary gland cancers, there's so many different opportunities for off-label use of different agents in this setting. What this really requires is a recognition of the importance of the question, as well as the limitations of our current knowledge, which is that randomly selecting different HER2-directed combinations or agents is really not serving the patient in their best interest. We really need to better understand how to optimally treat these patients. What we really need to do now is understand best how to optimize the utilization and administration of these drugs.
I think you've laid it out pretty perfectly. And hopefully this will help to get the word out a bit more about this trial and the opportunity to, as you said, establish for the first time a standard of care for these patients. So, Dr. Ho, we want to thank you again for joining us on the NRG Oncology podcast and speaking about HER2-positive salivary cancers.
Thank you so much for the opportunity. Really enjoyed it.
Today, we were joined by Dr. Alan Ho speaking about NRG oncology HN010 for HER2-positive cancers of the salivary glands. If your practice is seeing any number of salivary gland cancers, we hope that you might consider offering HN010 to your patients. The NRG Oncology Group is supported by grant funding from the National Cancer Institutes, and content of this podcast does not necessarily reflect the official views of the National Institutes of Health. Thanks everyone for tuning in, and happy clinical trials.